evening, everyone, and thank you guys so much for joining us again for this community outreach to try to help educate our colleagues, especially across multiple specialties, in the best way to identify and how to manage patients that come into our clinic presenting with symptoms suggestive of interstitial lung disease. Tonight, we're going to go through some cases. So that's really a fun thing. You're going to have Rebekah Edwards, who joined me a couple of weeks ago at the more didactic presentation, and she's going to help us go through these cases as well. Her expertise is very well known, and she is a pulmonology PA that works down at Norton Thoracic Institute. I am Candace. I am a rheumatology PA, and I work at Arizona Arthritis and Rheumatology Associates. All right, so let's start with our first case. Basically, it's entitled, I Thought RA Was Just About Joints. And as you guys know, almost all autoimmune diseases can have a systemic spillover effect. So it's never just about joints. Our first patient here, his name is LBJ. I kind of wondered if it was LeBron James. I don't know. It just was what came to my mind when I first saw it. He's 67. He is a male, and he's complaining of increasing fatigue, increasing shortness of breath, especially when he is exerting. And this has been progressively getting worse over the past 6 months. Like we talked about last time, it is very important when you're asking your patients about fatigue to try to tease out, because fatigue is often multifactorial, what is driving their fatigue. And also, when you're discussing shortness of breath with these patients, make sure that you ask them about shortness of breath when they're climbing stairs or when they're walking, because a lot of times they will just talk to you about how they're feeling in the moment. And a lot of times while they're just sitting still without exerting, especially if they're not holding much of a conversation, they may not have a lot of shortness of breath. Here you can see his past medical history. He has been diagnosed with seropositive RA. This was about 4 years ago. You can see his RA serologies are quite high. His rheumatoid factor is greater than 300, and his anti-CCP is greater than 60. He was started on methotrexate, which, as we all know, is the gold standard for the treatment of RA. And then that didn't appear to quite do it, so they went ahead and added a biologic, adalimumab. And this was added about 2 years ago. However, it appears his disease is a little bit recalcitrant, and it's not quite responding very well. So what features in this history would make you suspicious for increased risk of interstitial lung disease? Well, the fact that he is a little bit of an older gentleman at 67, I don't want to say 67's old because I'm not too far from there, but he is 67. He is also a male. Both of these factors increase risk for interstitial lung disease. The fact that his RA is very seropositive, this too increases his risk for developing ILD. And the fact that he has had uncontrolled disease probably for the better part of the 4 years that he's been diagnosed, this also increases risk.
Yeah, this feels like the classic patient who comes to pulmonary clinic with RA, like older, high markers, and then often smoking history is the other one that actually they tend to get ILD more often.
Absolutely. All right. So here, your primary care physician was listening to their lungs because they, again, were complaining of shortness of breath. And they noticed some inspiratory crackles, which are pretty classic findings for people who are going to present, or maybe first findings for people with interstitial lung disease. A lot of times it's like Velcro-y sounding. They did do a pulse ox on him and found that his oxygen sats were normal at rest, but then they got him up and walked him around, and they found that he actually desatted quite quickly. They ordered a chest x-ray and saw some abnormal interstitial markings, and so they decided to go ahead and order some pulmonary function test. PFTs are very important. It's important to order the entire PFT panel and not just spirometry. As you can see here, the FVC, which is your forced vital capacity, so basically the amount of air one can forcibly push out after a full inhalation, is around 65. And his DLCO, which is the diffuse lung capacity, carbon monoxide capacity. So this talks about the exchange of gases between the lungs and the blood. And you can see that's about 41%. Ironically, it is often first seen in the DLCO when there's going to be a problem. So make sure you're getting both pieces of PFTs. Forced vital capacities of greater than 80 are normal, and anything less than that starts to show issues with possible restrictive patterns. 65 falls kind of in the moderate restrictive range, and the DLCO is also indicative of moderate restriction. Moving on to his high-res chest CT, we see basilar predominance, okay, which is pretty typical. Reticulations with honeycombing. Honeycombing, we know, is often seen with this UIP pattern. Unfortunately, the UIP pattern does not always yield the best prognosis, so that's not exactly what we want to see. NSIP is more specifically seen with ground glass features and tends to have a little bit better prognosis. So what do ACR/chest, the chest 2023 guidelines recommend for the next step for suspected rheumatoid arthritis-associated interstitial lung disease? Well, the first thing I'm going to do when I see these numbers is refer him over to Rebekah. Probably get on the phone with her, say, hey, I got a guy. Can you get him in pretty quick? But in the meantime, I would encourage him probably to maybe stop his methotrexate. We need to get, from my standpoint, I need to get his rheumatoid arthritis under better control. So I'm going to start having discussions with this gentleman about trying to do that. So maybe we need to think about changing his biologics. There's several options that would be good, in my opinion. I think we could go with something like Orencia. We could also use Rituxan. Actemra may also be something I would think about. And if necessary, we could give him a short course of steroids. I want to make sure that I also have an echocardiogram on him. I like to do those once a year. So here we go. He's going over to see Rebekah. She confirms the diagnosis of RA with interstitial lung disease, that UIP phenotype, and notices he was on the methotrexate and the adalimumab about 2 years. She says also, hey, look at that high titer rheumatoid factor, the fact that he's a little bit older, and that his CCP was also positive. So what baseline and follow-up assessments would you establish for this patient? Like I said, get those baseline PFTs. I do them initially, and then for someone like this who is in their first years of developing maybe ILD, I repeat them about every 3 months. I'll do this up through the first year. I'll also get a high-res chest CT at baseline, both sitting and laying, and then I repeat that as needed. I don't always repeat it annually, but probably for this patient, I would repeat it in 1 year as well. So the question is should methotrexate be continued? And I want to kind of pick Rebekah's brain about this because in the past, I know methotrexate has really gotten a bad rap, especially when it comes to the lungs. There's always the potential for methotrexate pneumonitis. And so a lot of people say, hey, you should just probably avoid methotrexate if at all possible and go with something like mycophenolate. Mycophenolate has been shown to work really well in the lungs, and it's even often better tolerated. Rebekah, what are your thoughts on this?
Yeah. I think, like, historically, we've definitely made methotrexate kind of the villain. And certainly there's well-reported methotrexate toxicity. And so it is a concern. But we do know that in a patient like this who's presented with rheumatoid arthritis, we know about 10% of these folks are going to get ILD. We know they very commonly present with this UIP phenotype. So if I'm looking at this patient in the absence of other things, I'm going to kind of assume that these interstitial changes are from the rheumatoid arthritis itself. Um, Now, should we continue methotrexate? You're going to be hard pressed to find pulmonary who wants to continue it, just because we don't want to muddy the water as time goes on. We don't really want to continue something that we know could potentially um, have a pneumotoxic side effect that's well known. So we'll usually stop it. Like you said, we like mycophenolate. It works great for a rheumatoid lung. Doesn't seem to work so great for rheumatoid joint. But I think like the key here in this patient, like you said, Candace, it's really good control of their RA. And then when you have a UIP phenotype, we're thinking a lot, one about the inflammatory control, so the rheumatoid arthritis control. And I think some of our drug choices are a little bit different when we think about lung. And then we're thinking about really controlling like this fibrotic phenotype that we know UIP predicts. So I probably would still stop my methotrexate. Long way of saying that.
Yep, I agree. All right, so now it's time to think about and talk to the patient about our treatment plan and how we might want to alter that a little bit. So one possibility is we could initiate nintedanib. Another thing would be to continue him on some low-dose short-term prednisone. The thing about that is that you have to really push that this is bridge therapy from getting him from active disease to hopefully somewhat in a low disease activity or even remission. Just make sure that your patients are super aware that it has a beginning and it has an end. Their long-term prednisone use is not part of the treatment plan. And then they often said, hey, we could also switch again to abatacept for his rheumatoid arthritis control and consider stopping the methotrexate. Make sure they're up to date on all of their age-appropriate immunizations. So pneumococcal, influenza, I even think zoster should go in there as well. COVID-19 is listed here. Again, you're going to stay on top of those PFTs because you really want to catch progression early. Repeat those high-res chest CTs at the end of the first year. So what evidence supports the use of antifibrotics in RA with interstitial lung disease? Well, like we all know with our RA patients and what we talk to them about with their joints is one reason it's very important to get their disease under control early is because both of these disease states can do irreversible damage, okay? And once the damage is done, there's just no turning back time, okay? So I am a big proponent of being aggressive with antifibrotics. I feel like number one, it prevents, if at all possible, irreversible lung damage. And I think it also improves patient quality of life. Now, also, you got to make shared decision making a big part of the conversation because some patients are going to want this. And some patients, believe it or not, may not because of potential side effects or just fear of unknown. Now, which biologics might you prefer? I like the abatacept option. I would probably, in my opinion, go reach for something like Rituxan or maybe even Actemra. We know Actemra has done some good things in the lungs. It has been studied and found to be effective in our patients with diffuse systemic sclerosis, but one would hope maybe, that it would also be effective in interstitial lung disease associated with RA, which it also has an FDA indication for the treatment of. All right. So now let's kind of rewind and kind of wrap up this case. As you can see here, some of their RA patients are at high risk for developing ILD, and you need to be proactively screening. So talk to your patients about potential signs and symptoms of ILD. If they have any indication that this could be coming, go ahead and get that baseline high-res chest CT, those PFTs, because these are how you're going to catch the early interstitial lung disease. UIP doesn't carry the best prognosis, but antifibrotics, when utilized, can slow down the decline. And then just know that you're going to need to collaborate really closely with your pulm colleagues to get their input and also for their ongoing monitoring as well.
Great. Yeah. And I will say specifically, RAUIP, we have good data that those patients do worse. They have a trajectory similar to IPF. And so I'm with you, Candace. We tend to be pretty aggressive about antifibrotics in those folks. Case 2. Okay, it's getting harder to breathe. This one, we're going to go through progressive ILD in the setting of systemic sclerosis. Let me just get control of there we go. Oh, all right, so we have DA. This is a 56-year-old Caucasian woman, and she is coming to clinic complaining of worse dyspnea over the past 6 months. She also has a dry cough, and of note, she has a known history of diffuse cutaneous systemic sclerosis, which was diagnosed about 2 years ago. So on exam, she's got skin thickening proximal to her elbows, she's got Raynaud's, and she's got GERD. Her antibody profile, we've got a positive SCL70. So as we sit and look at her right off the bat and we think about her risk of developing ILD, these antibody profiles really give us a lot of information. So we know that people who have a positive SCL70 right off the bat are at the highest risk of developing interstitial lung disease. And that typically tends to happen in that first 5 years after their diagnosis, in opposed to people who have, say, like a centromere antibody, which tends to be a little bit more protective against ILD, and fewer of those people will develop it. Um, in these sort of patients, so ACR chest guidelines recommend that even in the absence of symptoms, that we screen these folks with a full PFT and a high resolution CT chest. So certainly by the time they're coming with symptoms, that's the testing that I would tend to pursue. Candace, any additional thoughts on that?
No, I just think, again, recognizing it early, getting it done right off the bat when these people walk through the doors, just getting baselines, so that you have something to compare to and down the road.
Yeah, that's true. And I will say, if you look at the body of evidence on systemic sclerosis, about 90% of people will have abnormal CTs, and maybe, 50-ish% of people who have an SCL70 up to that's been documented to have ILD. So getting that imaging is super helpful to have something to compare to. So this nice woman, she's had worsening dyspnea of the last 6 months. She gets walked in clinic, and there is in fact some desaturation. A little pearl, if you order a walking test outside, is sometimes in these folks asking for a forehead probe is really helpful if they've got bad Raynaud's to make sure you're getting an accurate oxygen reading. PFT, she's got an FVC of 71%. So we are showing some restriction there. We've got a DLCO of 52%. And it sounds like whoever was following her had a nice baseline for us because it says downtrending from baseline. And then high resolution CT chest. So we're seeing early honeycombing. And again, we've got that UIP like pattern, which we have also seen well described in scleroderma. So, what are the next steps in management for this woman? So for us, we're going to start thinking about medication to slow down the rate of decline in her lung function. We don't have anything to get rid of fibrotic changes, so UIP pattern is irreversible, but we want to be slowing that down. So, we've got actually, from a pulmonary standpoint, we've got some options right up front. We tend to go with mycophenolate just because that tends to be better tolerated as a first line, more like immunomodulatory agent. And then you can actually use OFEV as a first line therapy. So I probably would discuss this with the patient and kind of feel out what they'd like to try first. I think also their non pulmonary manifestations would give us more information about which of those medications to pursue. Certainly, in people who have UIP, just like we were talking about in the last case, we tend to be aggressive about getting people on antifibrotic therapy. With UIP pattern, it's typically about when they'll progress, not if. Um, for initiating treatment or for a transplant, we've kind of talked about initiating treatment. As far as referral to transplant, what I will say is that anybody who has a UIP pattern, you've already met the criteria to refer to a lung transplant center. Now, it doesn't mean the patient will get listed for transplant right off the bat, but it means that relationship starts. And that's a really important piece for autoimmune patients, specifically systemic sclerosis, because there's just more to tease out in these folks, specifically when we're talking about esophageal dysmotility and things like that. So, err on the side of sending the patient early. Um, and sometimes that's a couple visit conversation with patients for them to feel comfortable, but you can go for a meet and greet. Just because you go for the consultation doesn't mean you will be a transplant candidate or even that you have to choose to pursue it. So this nice woman decided to initiate mycophenolate. She was referred to the transplant clinic for consideration, reviewed vaccine needs, and introduced the idea of palliative care to help us with symptom management, advanced directives, all of that kind of thing. So, what role do non pharmacologic interventions play here? So, a few things from my perspective, and then I'm curious to see what you think, Candace. So, from my perspective, we like to get people plugged into pulmonary rehab. um, Honestly, pulmonary diseases tend to be muscle wasting. And if there's any nutrition standpoint, we really do work on keeping up people's muscle mass. So we send them to pulmonary rehab. Like was mentioned, we typically talk about vaccine needs. And then as more of just, I suppose, an adjunct type of thing, we tend to look a lot at like esophageal management, doing like aspiration precautions, stuff like that, to try to keep the lungs as clean as possible. Any thoughts from the rheumatology perspective, Candace?
Yeah, we always, really encourage our patients who are having anything autoimmune disease, to really focus on kind of their core health. Also to try to optimize that, really focus on what they're eating, eat clean, maybe try an anti-inflammatory diet. Always encourage them to really push tons of PO fluids, like, water, obviously, exercise as tolerated in this case, and then to always work on decreasing stress, increase in sleep, get good quality sleep. What are your thoughts on using the like percussive type vest? Does that play a role at all with these patients?
Yeah, it can. I've had a couple of patients with scleroderma who had quite a bit of bronchiectasis, so like kind of that widening of the airways. And so I have used the vest with a lot of success on quite a few occasions for people who have just like a lot of mucus production. I think it's fantastic.
Wonderful. Yeah.
Yeah, you can pair it with hypertonic saline, which will make you cough right off the bat, but sometimes ends up alleviating the cough a little bit the rest of the day if you've kind of got some of that out first thing in the morning and then before you go to bed.
Absolutely.
How do we monitor and adjust therapy? So I will tell you, these are the patients they do tend to watch really, really closely. So I'll also tend to do PFTs every 3 months. We'll tend to image them around every year, or if something's really changed. And so what I'm going to be watching for is I'm going to be watching for meaningful declines. So we're going to be looking for declines in their forced vital capacity. We're going to be looking for increase in symptoms, increase in worsening on their CT. So as you all know, when we're talking about meeting a progressive diagnosis, we're looking for 2 out of the 3, a decline in forced vital capacity on PFT or DLCO, increased respiratory symptoms or worsened CT. If you meet 2 out of 3 of those in the previous year, you meet the criteria for progressive fibrotic changes. And those patients, we always start on antifibrotic therapy. Okay. So we want to recognize our high risk folks in systemic sclerosis. So anybody who's got a systemic sclerosis diagnosis is an increased risk for ILD, but specifically our folks who have that SCL70 antibody. It's important to have early recognition and particularly to note the progressive fibrotic phenotypes in these folks. So those are the ones who are going to progress even if their inflammatory disease is well controlled. They're going to continue in this like fibrotic pathway, and those are the ones we want to use antifibrotics in, OFEV probably being the best studied one in this particular population. We want to initiate immunomodulator therapy and timing of antifibrotic therapy, and then timing of referral for transplant. Again, err on the side of just being a little bit more aggressive with these folks. Okay. So I think both of these cases here have given us some good pearls and reminders. I think some of it's just our general stance, like you were saying, Candace, of trying to be proactive and creating baselines for these folks so that if something changes, we know about it. I think one of the greatest pearls I learned from one of my rheumatology colleagues is she'll often, like you said, Candace, ask them about how exercise is going to try to like tease out if they're actually short of breath. And I think that's very helpful to incorporate.
Yeah, and we also on our end appreciate the progress that's been made in our abilities to help. Slow down the progression and improve quality of life in our patients. Um, we're very fortunate to have a great ILD clinic here locally, but we also note that there are patients, like I have one who I can barely get her to come see me. So for me to think she's going to come see me and go see a pulmonologist on a regular basis is kind of, I think, a little bit foolish on my part. So with her, I am more aggressive and I have actually prescribed her OFEV in hopes that we can, slow things down. But it's only because of the wonderful pulmonology colleagues that I have that have taught me so much about how to manage interstitial lung disease and all of the wonderful treatment options that now exist for these patients. So for any rheumatologic APC out there, or even primary care, who doesn't have, a direct pipeline to an interstitial lung disease clinic or pulmonologist that really finds it fascinating, just don't be afraid. Get in there. Try the best you can to help these folks, and reach out to your pulmonary colleagues who are happy to help.
Yeah, and we love partnering with rheumatology. We're lucky that we have so many rheumatology clinicians, like we were speaking about, here in the Phoenix area. And what I will say is that our patients trust their rheumatology folks, and they always go, "I have to go back and talk to my rheumatologist." So I think our collaboration really is like the key, and the patients getting what they want. So anyway, it's a joy to be part of this conversation, and I'm grateful for all you do for our mutual patients, Candace.
Absolutely. We thank you as well. And thank you guys all for your participation. We hope you found it helpful. And best of luck with all of your patients.
Yes, have a good night.